So today we're having the topic, people are staring, I'm blocking the number.
I'm sorry.
It's the same number, no, I don't know. Today we're going to be talking about trauma-informed care by Dr. Andrea Clements and Rebecca Haas. Rebecca, here, I guess, are you starting out?
Becky. Yeah, I'm starting out, yeah.
Actually had a long career in the ministry, in Christian ministry, and then went to work for all places, first ETSU, but then the police department. So you might wonder what Christian ministry and the police department, or ETSU for that matter, have in common. But for the last few years, she's been working on crime prevention programs and gotten involved with this topic of trauma-informed care, and she'll explain how that works. Our second speaker is Dr. Andrea Clements. She's been a psychology professor here since 1995. So it's going to stay a while, I think. It's going to work out. But she has done a lot of research on trauma-informed care, ACEs, which you've been hearing about, as it impacts, and religiosity is another, and the protective effects of religious beliefs on people. So she's worked a lot with Beth Bailey, who our department collaborates on perinatal health issues. I just want to put one little quick plug, especially to the residents. You've been hearing about ACEs, right? We've talked about them several times now. In my talk a couple weeks ago, we talked about ACEs being more concentrated in poor folks. We talked about how ACEs drive downstream health problems. You guys are all becoming ACEs experts, I hope, because I think trauma-informed care is, to me, the response to a lot of this. But honestly, to me, it's the way to view our patients very differently. Andy Garner, I don't know if you heard Andy Garner, pediatrician, leading expert in this area, has published a number of policy papers with the American Academy. He basically says if you can learn trauma-informed care, it allows you to understand where people have come from and how they've gotten to the place where they are in their life when they're struggling. So I think it's a wonderful framework for us as pediatricians to embrace. It's being trained all over the country, by the way, mostly in mental health and now into physical health services. So I want to put in a huge endorsement that this is the future of pediatrics. Can I say it any more bluntly? I guess.
Yeah, very good.
And my talk, we talked about Dr. Sketsina's project we just had a meeting about where we're incorporating this into our clinic. So this is really part of well child care and general pediatric care.
Wonderful, wonderful. Great introduction.
Oh, one last thing. We're going to be passing around sign-up sheets. Whenever they give talks, they ask people voluntarily to put their name, organization, email, and they like to communicate with you. It's kind of a network to keep you informed of things related to ACEs and trauma-informed care. Is that fair? So I'll start.
Okay. Is that too loud? Okay, well, it's really great to be here today. I'm all wired up. Just imagine your mother working at the police department, and that's like me being there. I didn't really have a background in criminal justice, but maybe in a way that's really helped me to see some of the things in our community through eyes that maybe took a different look. So some of the programs that I do in community crime prevention, when I first heard about ACEs in 2014, when our chief had me write a grant for our Family Justice Center, I realized that all the programming we were doing really led back to ACEs, led back to that. So it just made sense to educate our community. And Dr. Clements and I have been longtime friends, and if you get into my cell phone, you could get into my projects. And so we connected in 2015, and I said, let's just train our community. And so with really no grant dollars and some help from SAMHSA on a draft course, in less than 2 years, we've trained over 2,000 professionals and created a system of care that I was at a national summit in Philadelphia last week talking about. So I really appreciate this opportunity today, and Dr. Woods and Dr. Sketsina for bringing this to your attention. So we're going to cover in less than an hour what we usually have about 4 hours to cover, and maybe there'll be more opportunities. So this is really a quick overview. So my part, I'm going to take the first part and then Andy will bring it home. So we're going to help from some of the original trauma training from SAMHSA. Understanding trauma, And so what this module is going to kind of help you to get a grasp on is the underlying question, not what's wrong with you, but what has happened to you. And then learn to recognize symptoms, or as we call it the police department or in the school system, problem behaviors. Learn to recognize problem behaviors, possibly are telling a story. And then lastly, it's not a dark message, it's a healing message, and that healing can happen through nurturing relationships. Andy and I really love the best when we can train a group in a school, and we have the bus driver and the cafeteria workers and people that just have encounters with the kids, just because you can be therapeutic without being a therapist. So the first thing we're going to do is watch this video about the difference between empathy and sympathy. It's about 2 minutes.
Very different than sympathy. Empathy.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, "I'm stuck, it's dark, I'm overwhelmed." And then we look and we say, "Hey, you can climb down. I know what it's like down here, and you're not alone." Sympathy is, "Ooh, it's bad, no, you want a sandwich?" Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with "at least." And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, "I don't even know what to say right now. I'm just so glad you told me." Because the truth is, rarely can a response make something better. What makes something better is connection.
Taking or seeing it from the other person's side, to stay out of judgment, to recognize emotion in other people, but most importantly, communicate this understanding. If we had time today, Andy and I both could tell you stories. Me being at the police department for almost 4 years, we had started a program with felony offenders with addictions, and you all know I'm preaching to the choir today as far as the drug addiction and the babies and the health problems related to that. But many of the individuals in that program, one lady in particular, her charges were manufacturing meth, and now she's almost 4 years clean, but told a story of how at 8 she would hold her mother's arm while her mother shot heroin up, and if the man of the hour wasn't around, she would keep her mother from drowning, from falling in the toilet, because she'd be so violently sick. But her sister would be screaming, "Just let her drown, just let her drown." And one time her mother was gone for 2 weeks while she and a 10-year-old sister, she was 6, and a 4-week-old sister were left alone for 2 weeks. And they would hold a mirror under the baby's nose to see if the baby was alive. And when I hear stories like that, I say to myself, I could be you and you could be me. You don't pick where you show up in life. So the first day I ever met her, and she was telling a little bit of her story in the group, I said to her, I said, "I'm so sorry that is your story. I can't, I'm a mother. I'm a grandmother. I can't imagine a mother being the one that introduces you to heroin. And when I was back there a few weeks later, she saw me and put a little piece of paper in my pocket. And I told her while she was in the program, there's counseling, there's services you can avail yourself to, that somebody needed to help you with that as a child you were in that kind of environment, and find some resolve and closure. So when I was there a few weeks ago, a few weeks after that, she put a little piece of paper in my pocket. And when I got home that night, I forgot about it, and I opened it, and it said, "Thank you, Miss Becky, for treating me like a person." And now she's been out of the program, almost 4 years clean, and Mountain States had reached out about doing some interviews, and she said, I'll help with an interview if Becky will be there with me. And so we forged a kind of a bond of trust. So I didn't really go into all the nuts and bolts and things in her childhood, but just that simple connection, I guess me as a mother, to think about that. So another thing that drew me to this subject matter was I created a notebook, and I put in all the kind of programs I work with the police department, juvenile court, educators, mental health, community garden, neighborhood rebuilding, and I began to research for several months, was there anything related to ACEs and trauma that made a difference in those programmings, and very quickly filled that notebook up and began to see a bunch of outcomes. And one of the ones that's kind of the more famous in this network is in Lincoln Alternative High School in Washington State. A principal had a very violent high school and couldn't seem to get kids to stay in school, graduate, and he learned about ACEs, so he had his whole staff trained, and then they sat down together and said, what can we do here in a school that make the school more trauma responsive in practice? So they decided, first of all, that the in-school suspension would be something they changed. So they softened the room, and when Johnny would come in and having used the F word on the teacher and had to go to in-school suspension, the teacher would say, Johnny, what's going on? And this is a true story. And Johnny said, well, my dad didn't come home last night. When he came in this morning, he'd been out partying because he lost his job. He and Mom got in a fight. He kicked her in the face. Her teeth were bleeding. So I didn't really mean that at the teacher. I really meant that at my dad. And in 1 year, suspensions went down from 798 to 135. And in 1 year, graduations rose from 9 to 60. So what is trauma? The SAMHSA definitions, the 3 E's. Individual trauma results from an event, a series of events, or a set of circumstances experienced by an individual that are physically or emotionally harmful or life-threatening, that can have lasting adverse effects on the individual's functioning, mental, social, physical, social, emotional, or spiritual well-being. So the 3 E's, event, experience, and effects. So the first E are the potential events, and you'll see them kind of arranged in a couple of columns there: abuse, chronic stressors, and loss. Some of the events could be a one-time event, maybe a loss of a parent, a loss of a job, but some can be ongoing or chronic stressors. And if we had more time today, we could show you some slides and graphs of how chronic stress, the stress level never comes down. And those are poverty, racism, maybe someone in the home has an ongoing medical situation, and then there's loss. So these are the kind of events that can be traumatic. But it's not just the event. You and I both can experience the same event, and maybe it's not traumatic to you, and it is to me. So the next thing is the experience of that event, and that can be affected by how did it happen, when did it happen, where did it happen, and how often. So it's the individual's experience of the event, not necessarily the event itself, that's traumatizing. And then the third E of the 3 E's are the effects. The effect of trauma on an individual can be conceptualized as a normal response to an abnormal situation. Many times in the criminal justice world, particularly where it's drug crimes, or someone growing up with a parent with addictions, that they feel like that's the norm. And so many of the things, Andy's been a part of those events, that in the probation program, I can use city facilities, being a city staffer. And so we would reserve a park, and when everybody's passing their drug screens, has perfect attendance in the program, we would just go play kickball. And Chick-fil-A donate a bunch of chicken box lunches, and we were just out there for an afternoon in the sun playing kickball, not thinking about criminal histories or drug addiction. And we really wanted the individuals to see that, that maybe what has become a normal situation for you is not the way maybe other people live. A couple of good quotes: we don't see things the way they are, we see things the way we are. And then survival mode is supposed to be a phase that helps save your life, not meant to be how you live. So some of the physical reactions that are normal to trauma, and so we want to begin to shift your thinking instead of symptoms to adaptations, are things like aches and pains, and the child at school with the chronic stomach ache, sweating, changes in sleep, loss of sleep, more susceptible to cold and illness, and at risk for choosing risky behaviors. And here's some negative thoughts that can go along as well. Guilt, shame, having negative expectations. For about 5 years, I did classes for juvenile court, and some of the most negative mindsets in those young people, by just having so many negative outcomes in their life, that their slant in life was towards negative. Negative emotions, depression, fear. So now, instead of just treating the depression or bipolar, some of those things, now we understand how to connect the dots, which is very, very exciting, okay? Here's some things with behavior. Andy and I did some training for those working with the homeless populations, and you can see so many of these characteristics are present. Learning difficulties. Difficulty concentrating, remembering, poor planning. So again, now when a teacher encounters these kinds of behaviors, wondering why, Johnny's normally a pretty good student, pretty engaged, pretty good behavior, but then all of a sudden one day everything's off the charts. So instead of immediately resorting to punitive approach, maybe now that we're trauma informed, every day in Washington County there's an average of 9 to 12 calls domestic violence, and so children are witnessing violence in their home. And so maybe Johnny's coming to school and witnessed, or maybe he's even called 911, and now he's seen his father be arrested, or one of the parents be arrested, and now Johnny's having to go to school, and so those kind of things can totally kind of frame a new way of looking at these behaviors, all right? All right, now I'm going to show this little video. It's actually about 10 minutes long. The reason we don't like to take it out of this is because it's just very poignant. It's a true story. Actors portray this. The little girl now is a grown adult, and she tells her story, but this really helps you to see violence and trauma through the eyes and understanding of a child, okay? My husband always says, if I'd have just been a fish, I wouldn't have to breathe while I talk. I could just have gills and...
Sometimes someone hurts you so bad.
I don't think you understand.
It stops hurting at all. Until something makes you feel again. And then it all comes back. Every word, every hurt, every moment. How could you ever understand where I come from? Even if you ask, even if you listen, you do not really hear or see or feel. You don't remember my story. You haven't walked my path. You haven't seen what I've seen. My past defines me. This is who I am. I am unseen, unheard, unwanted. That is what I am, if even I am anything. It seemed like the same thing that held me up forced me down. And the world turned upside down, and order disappeared. Nothing was how it was supposed to be. And a heavy sadness filled my soul. Deeper and deeper I fell within myself. And nothing could draw me out. Trapped in the misery of my life. Lost in the sorrow of my soul. Unable to see the light. Unable to see the dawn. To feel. To hope.
What are you doing picking my fruit?
To dream. And I found the darkest days of my life kept coming. The blackest nights for my soul never stopped. It seemed like it was always nighttime and nightmares, and never morning. And maybe you wonder why, but mostly you try not to think about it, and try to get by, and try to survive. And all the other stuff seems so much like nothing, compared to just wanting the most important things back again. Like wishing you could see your mama's smile again, and hear her sing that one favorite song that always calmed you down when things were all messed up. Or if you couldn't have her back, At least get to take care of your baby brother. 'Cause you know he needs you. And he's gonna be so scared all alone. And who's gonna hold his hand and whisper it'll be all right to him? And who will whisper it to me?
Hi, Zoe. It's so good to have you here. Are you ready to come in?
I know I am helpless, dependent, desperate. But what happens when those you need the most threaten your very existence? I've heard plenty of promises, and they all sound the same. But push hard enough, and sooner or later, they all prove to be empty. The sun comes up every morning, but do you know where? Each place, it's somewhere different. It's hard to find east when you keep moving around. But at least it comes. It always comes. I've come to depend on that. And slowly seasons changed around me. And it seemed this time that maybe the world would not be pulled out from under me again. Feet safe, roots starting to grow, little buds of hope forming, slowly attempting to trust this new life.
Hi. Come on over. Let me show you what I got for you. Got you a gift.
I don't care about your dress. You think I care about this dress? I don't think you understand me, do you? I don't think you understand me.
I wish someone would tell me it's gonna be
Every
okay.
time I come home, I swear to God you touch me again, I will kill you.
Touch me! I don't care about that one day, maybe, I feel normal. That I won't always be alone. That I'll have a mommy who will hug me and be strong for me. Because maybe I can't do it all by myself.
Hi, yes. I'm calling to let you guys know that I have room for another placement. Thank you so much. Yes. They'll do it around. Okay, thanks, Shamika.
This, my past, my history, my story, is not my fault. It's not because of me. And doesn't have to be what defines my future. I am lovable. I am worthy of care. And that glimmer of light, it makes all the difference. The glimmers of light give me hope that someday my summer will come.
Analysis we could do from that video. You hear the girl surmising that she is worthless, she has no value, basically because of the way she's been treated. And look at the things she does, like trying to do her homework and reaches out to the adult figure there who throws the book and then she runs off, carries her back in. Now those things are not her fault. Now this is not a message that's an excuse for crime or bad behaviors or drugs, but the thing is we realize that if you put on your trauma-informed lens and you watch this film, then we even see things the police could have done differently, and we're working with police to do differently as far as trauma in a home with a child. When she goes for her school pictures, obviously it looks like she's got some black eyes. Can she help it that occurred the day before her school pictures? And then when she goes into foster care, the first foster home, when it wasn't right to launch a turntable over the deck, certainly, but do you think that foster mother could have resolved that differently than pulling her into the shower and hosing her down like a dog fight? Did you notice the next foster mother, as soon as she came to the door, she got right down on her level and greeted her, and when she was reading the book and tore the pages, that foster mother didn't come unglued and just kind of didn't really have a response. And then when the little girl pulled the dress out, obviously she's kind of having a flashback to that scene with her father, or the male figure there, and kind of triggered her. But notice immediately she came right back in with the dress on. Okay, so there's just so many good teaching points, and this will kind of wrap up my part. But that leads us to the brain development, understanding the brain development where trauma is concerned. So the brain development is developed from the bottom up. During childhood, the brain matures and brain-related capabilities develop in sequence. That's why my granddaughter, I expected fully that she would roll over, then crawl, then walk, and now I'm trying to teach her to say Grammy. She's wanting to say Meemaw. That's what they're teaching her, but maybe it was fun, but I want to be Grammy. Okay, sorry, subject diversion. So the fire alarm is the amygdala that's in your brain, and trust me, if a tiger ran in this room, we'd all be so thankful we had an amygdala. So we would be trying to only focus on surviving. But if in your life the tiger keeps running in the room, if the tiger runs in the room enough, all you have to see is a picture of a tiger and you're going to be set on that same trajectory course, all right? So the frontal lobes of the cortex actually shut down during survival, and the amygdala responses are only 3: fight, flight, or freeze. So these 3 little videos are about a minute each, and they're going to just go one right after the other. This is from the Harvard Child Development Center, and these really, really paint a picture, understanding, in my world, the cradle to prison pipeline. When you see that a child has to have help to develop their brain.
A child's experiences during the earliest years of life have a lasting impact on the architecture of the developing brain. Genes provide the basic blueprint, but experiences shape the process that determines whether a child's brain will provide a strong or weak foundation for all future learning, behavior, and health. During this important period of brain development, billions of brain cells called neurons send electrical signals to communicate with each other. These connections form circuits that become the basic foundation of brain architecture. Circuits and connections proliferate at a rapid pace and are reinforced through repeated use. Our experiences and environment dictate which circuits and connections get more use. Connections that are used more grow stronger and more permanent. Meanwhile, connections that are used less fade away through a normal process called pruning. Well-used circuits create lightning-fast pathways for neural signals to travel across regions of the brain. Simple circuits form first, providing a foundation for more complex circuits to build on later. Through this process, neurons form strong circuits and connections for emotions, motor skills, behavioral control, logic, language, and memory during the early critical period of development. With repeated use, these circuits become more efficient and connect to other areas of the brain more rapidly. While they originate in specific areas of the brain, the circuits are interconnected. You can't have one type of skill without the others to support it. Like building a house, everything is connected, and what comes first forms a foundation for all that comes later. The key to forming strong brain architecture is what's known as serve and return interaction with adults. In this developmental game, new neural connections form in the brain as young children instinctively serve through babbling, facial expressions, and gestures. And adults return the serve, responding in a very directed, meaningful way. It starts very early in life, when a baby coos and the adult interacts and directs the baby's attention to a face or hand. This interaction forms the foundation of brain architecture upon which all future development will be built. It helps create neural connections between all the different areas of the brain, building the emotional and cognitive skills children need in life. For example, here's how it works for literacy and language skills. When the baby sees an object, the adult says its name. This makes connections in the baby's brain between particular sounds and their corresponding objects. Later, adults show young children that those objects and sounds can also be represented by marks on a page. With continued support from adults, children then learn how to decipher writing and eventually to write themselves. Each stage builds on what came before. Ensuring that children have adult caregivers who consistently engage in serve and return interaction, beginning in infancy, builds a foundation in the brain for all the learning, behavior, and health that follow. Learning to deal with stress is an important part of healthy development. When experiencing stress, the stress response system is activated. The body and brain go on alert. There's an adrenaline rush, increased heart rate, and an increase in stress hormone levels. When the stress is relieved after a short time, or a young child receives support from caring adults, the stress response winds down and the body quickly returns to normal. In severe situations, such as ongoing abuse and neglect, where there is no caring adult to act as a buffer against the stress response stays activated. Even when there is no apparent physical harm, the extended absence of response from adults can activate the stress response system. Constant activation of the stress response overloads developing systems, with serious, lifelong consequences for the child. This is known as toxic stress. Over time, this results in a stress response system set permanently on high alert. In the areas of the brain dedicated to learning and reasoning, the neural connections that comprise brain architecture are weaker and fewer in number. Science shows that the prolonged activation of stress hormones in early childhood can actually reduce neural connections in these important areas of the brain at just the time when they should be growing new ones. Toxic stress can be avoided if we ensure that the environments in which children grow and develop are nurturing, stable, and engaging.
Turn principle requires someone else on the other side of the tennis court, and that is not always happening in homes. And so one of the goals of Andy and I in creating a trauma-informed system of care, if one of those children that is in a home where they witnessed violence during the night, likely their caregiver is not going to take them to a mental health service within the next day or week or year to process that confusing event, but that child does by law have to go to school. So what if we have advocates or Boys and Girls Club or Coalition for Kids? What if we were able to surround those children with advocates that understand these principles and can help mentor them and keep them in school and help them to succeed when they're not getting that at home? And so some of the curriculum that we use kind of illustrates the role of the parent in early childhood development, kind of like having an upstairs and a downstairs of a house. The upstairs being your cortex, the downstairs being the amygdala. And what happens if you remove the stairs? If you don't have the adult there to be nurturing and caregiving that helps a child move from that part of the brain back up to the calming part of their brain, then the child goes to school with a highly developed amygdala and not a very well developed cortex, and so that's why they begin to struggle in school. And so here's a couple of things. What does trauma look like? We've all seen the child that's all by themselves or hypervigilant, disconnected, over easily excited. And this is kind of some new information that's very exciting. The National Child Traumatic Stress Network did a kind of a layover here of trauma and symptoms, and then ADHD, and then look how much they overlap. And so this is really great information coming into our schools. So I'm going to let Andy wire up.
And you said that you've already done a good bit of ACE. Where did you go? A good bit of ACE training already, and so you may have already seen the ACE primer video. Have any? Yes, for the most part, do most people have it? Because I'm thinking, what do we want to get most to? I have too many things to hook on here. Just gonna. All right. So, in the interest of time and getting onto the so what do we do? That's the ACE primer video, which is online, and you're welcome. It just goes through the ACE study, and what the bottom line is, we know that early childhood experiences that are adverse predict all kinds of health issues, and I'm sure you have already seen that. So I'm going to go on to some of the other things because I want to protect your time for one thing. But just the bottom line is you have those experiences. You just saw the disrupted neurodevelopment and so forth, social, cognitive, behavioral things that you use to cope with those things that can then lead to further health problems, either physiological from the stress response or from abusing substances or overeating or undereating or not sleeping enough or choosing risky behaviors, whatever. But we know that outcomes tend to be worse for people who have experienced these adverse experiences early, and even adverse experiences as an adult, but the developmental part is happening when they're early. So I wanted to run through a little of that. You are probably well versed on the huge prevalence of various traumatic things, all the way from, my parents were divorced as a child. Well, that's half of the kids, to all kinds of other things going on, witnessing violence, sexual abuse, and kids in the juvenile justice system and so forth. So we know there's a problem. I mean, you're here because you know there's a problem. One of the things, though, that both of us find to be so, I guess, as bad as it sounds, but find it to be hopeful, is maybe we found that thing, or one of those things, that we can address and we can actually do something that makes a difference. We don't just treat symptoms and symptoms and symptoms. Maybe we can get at the problems and start to prevent or actually treat what's really going on. And so both of us are very hopeful. The beginning of the whole trainings that we do, it's like wah, wah, all the way through. So I want to get to but how can this look? And so I think this is because of all these things that it predicts, that early trauma predicts, mental health, admissions, the frequency, the medication, the severe symptoms and so forth are predicted by this early adversity. Trauma and substance abuse. Substance abuse is kind of my thing. I don't know, Dr. Wood didn't mention that I work on the NAS group with him, and that I just want to solve substance abuse. That's my thing. That's just my thing. So I have some ideas if you want to talk later. So this is just we started out putting this in because when Becky first brought this information to me, I was skeptical because I'm skeptical. And it's like, I don't know if that's really a thing. And so I started looking and saying, okay, there's really some science behind this, and okay, it's legit. Because sometimes she gets excited about things that, it's like, well, let's see if there's actually any research behind that. But I found out that there's a lot of research behind it, so that's good. I pulled this up, I think during the summer. I keep doing a PubMed search to see how many articles are out there, and the first time we did it, there were like 700. This was 1,318 just by putting in adverse childhood experience. It's probably double that by now. It's been a few months. So there are a lot of people doing research in the area, particularly the ACEs area, and I know you've already been taught a lot in the ACEs area, and it's like, yep, there's a problem. Yep, we've confirmed there's a problem. By golly, yep, there's a problem. Okay, well, let's get on to some solutions because we're convinced there's a problem. And so that's what I want to move on to, is what do we do? And so, yeah, we're convinced that there's a problem. And I and you both think diagnosis is great. We need to know what's going on. But treatment or cure is better. And so that's what we're working on. I think she mentioned we didn't have any money. Last year we had money to do a demonstration project to actually do some of the science to see if trauma-informed care is actually working. That died after a year because the funding dried up. So anyway, there's still research going on in this area, but it's a slow thing to say, yes, trauma-informed care is effective. We're beginning to see, yes, we can say, absolutely, we can train people to use it, so that's good. Now we've just got to see after they've used it if it has made a difference, which I think that it will. And so we've already got the screening recommendations, and I'm sure y'all have been through there. I assume you have shared this. The American Academy of Pediatrics has, yes, go ahead and screen for this. It should be part of practice. And not just in the kids, but in the parent, because you see the parents. If you see the kids, you see the parents. And so I think some of the stuff that is harder, it's easy to see, oh, this poor child, they're innocent, there's nothing, there's nothing going on, but or nothing that they've done to cause this, but then immediately it's, but you, bad parent, you have caused this. But a lot of those parents are those kids. They were those kids. And so that's what we want to kind of convey, is that, that even as we meet whoever we meet, in the back of our minds is, this could be symptoms of past trauma. This could be symptoms of past trauma. It's very generational. So kind of things that we look for, and that's all in that article. But what does the trauma-informed care, I also looked those up, and as of last summer, 1,612 articles now. So it's out there. It's out there. Hopefully, before long, some of ours will be out there. And so there's just a few of the types of things going on. And there's your implementing trauma-informed care approach in pediatric care networks, which I hoped would be a research article with results. It was not. It was, here's what we're doing. So we're doing it. So y'all I'll come study you. It's okay. But one of the things that, and this is from Dr. Felitti, who is one of the original ACE study authors. And this was kind of a first glimpse at what this may look like, what the results may be. And they did a study, 125,000 patients. Obviously, they weren't running them through themselves, but accumulating evidence from lots of practices, and found a significant reduction in visits to doctors and ER just by using, not by what they did with the ACE instrument, but just because they asked the questions. All they did was ask the question. There wasn't like a follow-up. It was just that was part of what they did. They talked about it, they went on. So it wasn't, we're getting these people into therapy or anything like that. It was just included as part of the practice, and they saw this great reduction. And one of the things, and this is not it's not experimental at all, but one of the things that seems to be the case, and I'm going to say that because I'm a researcher, so I have to say seems to be, but is just letting someone know that you know that you care, know that you're listening, know that you're acknowledging, seems to be very therapeutic. So it's not, we started out, when we started doing these trainings, we actually had, people were sort of scared of this. And so we started out with having counselors in the area trained. So the first 2 trainings we had were 2 days of counselors from all over the area trained in trauma-informed care and to do trauma groups and to address trauma in therapy and so forth, to have them ready, because it was like, we didn't know, we didn't really know what we were getting into. But then one thing that is reassuring, when they did the original ACE study, and you may have heard this, that the IRB required them to have therapists on call 24/7 through the whole study. 17,334 people, no one ever called. So no one, 17,000 people. So the thing is, it's kind of like when you have someone has a relative die and you say, oh, I didn't want to mention it because I didn't want to upset you. They know their relative died, you can mention it. It's not like, oh, darn, I forgot about that. And so when somebody has had these traumatic experiences, to acknowledge that is much kinder than to pretend it didn't happen. But we're uncomfortable, and you know, it's hard to do because, again, like that very first video, it's making yourself vulnerable, and we'll talk about that a little bit in just a minute. But anyway, so just the listening seems to be helpful. Okay, so what does this look like? I keep looking for the word. If you come up with a word, I have strategy, mindset, approach. We could use paradigm, but I hate that word, so I don't use it. It's just a thing of me. But so whatever it is that encourages providers of whatever kind, medical providers, counselors, teachers, bus drivers, whoever, to be aware of not just physical needs, but psychological and emotional. So focusing on someone as a person who has a context, not just, you know, a piece of meat that walks around, but somebody who actually comes from somewhere and has experiences. Approach people from a perspective of empathy, not blame for their circumstances. And that's hard. I know that's hard a lot of times. I know y'all see terrible things and kids in awful situations. I know you do, and I know it's very hard to separate that. And I can empathize with you, but I haven't been there, so I know you go through that. Treat everyone, clients, patients, fellow staff, hello, with respect as equal valued human beings. So everybody has value, everybody is important. And so just like Becky said, thank you for treating me like a person. So just treating everyone, each other, the clients, the boss, whoever, as people. And acknowledge trauma, encourage discussion of trauma to the extent that the person wants to talk about it. So part of being trauma informed is not just giving them the chance to talk about it, but also giving them the chance not to talk about it. So it's like they are the ones with the power and the relationship. So if they want to tell you about it, they can tell you about it. If they don't want to tell you about it, that's okay too. But we're still treating them as if bad things have happened, as if that could be some of the symptomology or whatever. Trauma-informed services are infused with the knowledge that trauma probably has happened. And I mentioned the just asking the questions. If you're living, particularly if it's an impoverished or an at-risk population, you don't even have to give them the ACE instrument. You can just assume that there is a high level of past traumatic something going on. Poverty is one, you know, so just assume that and go on from there. You want to start looking, when we do the full-blown training, we have a set of questions at the end where you can evaluate your own practice or office or wherever it is that you work. Some questions that you go through to look at, are there things that we're doing that might re-victimize people? Just like the little girl pulling the dress out, it's like you don't know what's a trigger, but are there things we're doing, you know, I mean, something that comes to mind, if you have, on campus, we have a sexual assault, they have a new grant where they're working on a program to have sane nurses on campus and things like that, so that if women have been sexually assaulted, they can be nurtured there instead of the previous, which was, you know, get in the back of my police car, little lady. I mean, the last thing you want is to have this big scary person in the middle of the night stuffing you in a car and driving away with you to bring you to the ER. So that kind of thing where we think through processes and what could we be doing that might be traumatic to the person. And sometimes that might involve asking them, is this, you know, if you notice behavior, is something here making you uncomfortable, you seem ill at ease or whatever, and they might tell you, you know, it's like, you look just like my abusive stepfather or whatever, I don't know, you know, but even asking the question can be trauma informed. Even if they say, no, it's fine, they might leave feeling like you cared enough to check, you know. So just little things like that. So it's not something you need graduate training for. It's just like, just be thoughtful. So assessing settings, procedures, whatever you're having them do that might be re-victimizing to them. Being respectful of their choices and control over themselves, over their treatment, over the treatment of their children, and so forth. And that's one of the big things here is a lot of people respect medical professionals. It's like, oh, well, you must know better because you're the doctor, or you must know better because you're the nurse, or whatever, the therapist, whatever. But sometimes it might be that somebody is uncomfortable with whatever, and they're just going along because they think they're supposed to and whatever, and they don't really feel like they have a choice. And I do this even in research. It's like, here is the 12-page consent form for the study. Go ahead and sign it. Let me know if you have any questions. It's like, well, I guess I'm supposed to. I'll sign it. Same thing with surgery. It's like, I'm going to be in pain unless I sign this paper. I guess I'll sign the paper. But giving the chance for questions and assuring people that it really is their choice, whether that they don't have to do whatever the treatment is or whatever, but also that they can discuss it with you. It's okay to question. And sometimes just giving somebody the opportunity to ask questions is fine. They'll go with it, but it's like, oh, wow, you cared enough to ask me my opinion about this. So, and thinking about being in partnership with the survivor, so kind of leveling the playing field. That's the same sort of thing with this, like, doctor, patient, whatever, but more, we're in this together, and sometimes that might be the kid is having problems. It might not be the parent, but working with the parent, what can we do? Had a great talk with my son's basketball coach earlier, same sort of thing. It's like, I'm just a parent, you're a coach, whatever, but he was very accommodating. It's like, yeah, let's work together, we can do this, whatever. So those kinds of things. So just people are people, and they're valuable, and so being kind of mutual with all of it. The idea of facilitating recovery, growth, resilience, and so forth, and that is shooting for the best in people. And I came out of an educational psychology background way once upon a time, decades ago. But you've probably heard of the studies where teachers, the ones with low expectations, have children that perform poorly, the teachers with high expectations, the same sort of thing. And this is not saying, well, you've got ACEs and so does your kid. Wish it had been different, sorry. No, it's like finding their strengths, finding the things that can be helpful, expecting things to get better, expecting improvement, and so forth. And so not just, you have this thing, here's the fix, but what can we do even better, to end up better than you started? And so having more of a hopeful outlook and so forth. Including non-traditional collaborations. Becky mentioned she worked in a church, I do religiosity research and so forth. That whole addiction thing, well, I'm going to do a quick plug for mobilizing the church to address addiction. We have some folks from here, which include me, and some folks from Duke University, and Roger Leonard, the chair of the board, the one that did the merger. Anyway, we're putting on a summit in May, which is going to bring together a bunch of addiction experts and some theological experts, and invite churches all over the area. And so we're trying to mobilize the Fuzzy Pew Army to address addiction. So if you want to talk more about that, I'll be glad to talk about it. But that's using those non-traditional collaborations. Who can we bring in? Who can we help? Who is the Army? And so, and I know a lot of times I mentioned the parents that you deal with. It might not be the parent that you're going to be able to, we saw foster care here. It may be foster parents. It may be, I don't know if you're familiar with Safe Families that are caring for these children instead of their parents who are in jail or absconded or whatever. So, but whoever, kind of a teamwork, work together. Emphasizing strengths, being culturally sensitive. So, where they came from, are there things, making use of their own communities, their own networks, instead of saying, well, our network is better, or you need to come here. Capitalize on the people that they trust, the people that they have in their circle, and so forth, and being sensitive about those kinds of things. And facilitating trust and safety, and come to a longer training and we'll tell you how to do that. All right, so the things that we're assuming that there is a connection between ACEs and health problems. I think you've got that. We're assuming that reducing childhood trauma is always going to be an aim of all of us. Nobody's going to say, no, I think they need a little more trauma. No, they don't. We are assuming that interventions to address past trauma and become trauma-informed will make a difference, improve health, improve, lots of things beyond health. We're assuming that that's also going to reduce substance abuse and mental health and physical health problems. And so we're assuming all that is true, and we think that trauma-informed care will do this. So far, we have not had anybody that has taken this back to their organization and said, nah, that didn't go very well. You should also ask us about Topper Academy, because it's like the Lincoln High School. We're seeing it right down the street here, and it's amazing, the things that have gone on there since August. All right, so why this? Anybody can implement it. It's cheap. You don't have to have a degree. You don't have to train. Well, you have to train people a little bit, but you don't have to be an expert or have a certificate or anything. Useful anywhere. I use it in my own house. It's kind of funny, the number of things that I run into. I think, oh, I should use a trauma-informed response to that. So I have 4 kids. It should be useful during or after trauma. Yes, should be useful with children or adults. So it's very, very broadly applicable. Okay, downsides. Yes, time consuming. I know you're sitting there thinking, what if I get involved with the life of every patient? I get that. I know you, probably most of you want to be, but even doing little bits of this is better than doing no bits of this. So time consuming, yes. It can be stressful. Feeling with people, if they hurt, you hurt. And this is something that has really, we've seen come true and true and true. And one of the things that we're starting to do is some training on self-care and just the caregiver burden of kind of feeling these feelings. And so we also do some trainings on ways to sort of diffuse that as well. And also in medicine, it's hard to be okay with the patient choosing some option that you know is not the healthiest option. Because if we're turning over control of themselves to themselves and they make bad decisions, I know that's hard. It's like, oh, but you need this thing, and I get that too. And you will have to come to terms. I can't tell you how to fix that, but just know that that they are valuable human beings who do have reasons for decisions that they make. But also, if you develop that relationship with them, they may trust you enough to be guided better than if you're just telling. All right, final thoughts. Can't solve all the problems. You can't solve all the problems. You can do this all day long, and you can't solve all the problems. Lots of people in our area, like she said, over 2,000 people. We've trained lots of people in this area. There's more people. We've trained people to train people in trauma-informed care. So it's getting around. And so we're going to start doing some research to see if it's getting around from the client side. We know from the practitioner side it is, but we don't know if it's filtering down to where people are perceiving that it is a trauma-informed environment. So we're going to start doing a study this spring, hopefully, to get at that in some specific locations. So we're ahead of the curve right now. We're one of those cities on the map as getting a system of trauma-informed care. And we would love to provide resources, either people to come and talk or materials or links or whatever you think would be helpful to learn more about this. We also do longer trainings. We've been doing like a general one in the fall and general in the spring, but we do them for specific organizations too. As we have time, we have some other people that do training as well that do a longer one, and that is us. Okay, so do you have any questions? Wow, we taught them everything. Yes?
Thanks for a great talk. Sorry, my voice is not very good, so I'm going to say anything. I think the thing that's most sort of encouraging out of this is what you said about just the asking in itself is helpful.
Right.
So
right.
Sometimes you worry that you're going to open a Pandora's box.
Yeah, we call it a can of worms, yes.
Why then should we ask all these questions? What on earth are we going to do? We don't have any resources to help them.
Right.
I think, and funnily enough, I didn't know about the study, but that's the conclusion we've come to after instituting our social determinants of health screener clinic, that just in the asking in itself seems to help.
Well, and you go all the way back to that first video where it's the person, the bear says, I don't even know what to say, I'm just glad you told me. And it's that, you don't have to fix, and we can't fix lots of things, but we can care. I call it just like being there with you. I read a book, they call it The Lost Art of Lament, where you just sit and be sad with somebody sometimes. You can't make it any better, but you can sit and be sad with them, so. Anything else? All right, well, you know where to find us. That's where we are.